Welcome everybody. My name's Siale, consultant psychiatrist here at Capri Hospital. Welcome to our August podcast. Looking forward to sharing my thoughts about some couple of interesting cases and a response to a question sent in to us from a GP in Bay of Plenty area. The question that was posed to us by the general practitioner was around prescribing what would be a safe amount of codeine to prescribe for a patient of his that was taking somewhere between 600 to 700 milligrams of codeine per day. And I think essentially the question was, there was two parts. The question wasn't posed this way, but the question was about, what would be a reasonable amount. And the GP was saying, the guidelines, the MIMS guidelines, sort of say that 360 milligrams of codeine is the maximum amount that we should safely prescribe. Now that's if you're prescribing for analgesic purposes, but clearly the patient was taking 600 to 700 milligrams per day, and I guess one of the concerns would be if you're going to only prescribe 300 milligrams a day in partnership with the patient in a view towards sort of reducing the codeine use. And doing what would be considered, a treatment for opioid dependency. The reality is that you have to actually start prescribing, close to or just under the amount that the patient was taking. Now, if the GP had decided that we were going to stick to the guidelines of no more than 360, then the patient would have experienced some opioid withdrawal symptoms. And I just wanted to draw everybody's attention to it's not widely used by primary care, but there is a clinical opiate withdrawal scale. It's called the COWS. And the COWS is part of the rating scale that the Ministry of Health guidelines, the Matariki guidelines, which you can find online. And if I was just to go through those, you basically rate out of 4 resting pulse rate, amount of sweating, restlessness, pupil size, bone and joint aches, runny nose or teary eyes, gastric upset, tremor, yawning, anxiety levels, and the presence of goosebumps. And then you total that score, and each of those ratings is clearly out of 4. And if they rate sort of 5 to 12, it's mild. If they score between 13 and 24, it's moderate. And between 25 and 36, moderately severe. Anything more than 36 is severe withdrawal. And so one of the questions I was asking myself is, is it a reasonably safe thing for general practitioners to be doing opioid detox, community opioid detox? Because it's commonplace now for benzodiazepine or alcohol withdrawal to be managed in the community, and for GPs, often in line with community alcohol and drug services to be prescribing for people withdrawing. And I guess, from a medical point of view, opioid detox is extremely, the withdrawal symptoms are severe, particularly if there's no active treatment. If people go essentially stop their opioid use and just go through acute detox that way, that's not recommended, and certainly is very, very symptomatic for clients. The question that I guess is that I'm wanting to ask myself is, should a GP do, the question was what would be the maximum dose prescribed, and the answer to that is actually a dose just slightly lower than the amount that they're using so that the withdrawal symptoms aren't severe. And then you would just incrementally reduce that over a slow period of time. You could do, once with any withdrawal symptoms disappear, you could reduce the dose weekly. But there's a more important question about safety, and would it be medico-legally acceptable for a GP to do that without sort of consultation with addiction services? And the answer to that question is probably not. Probably the advice that I would give, if you've come across any of your patients that are taking that level of sort of codeine, you're probably best to try to manage that in conjunction with community alcohol and drug services and get an addiction expert involved, rather than try to manage that on your own. second part of our podcast today is on a related matter that we're finding frequently here at Capri Hospital. And essentially what we're finding is that people that have got a codeine dependency or are taking significant amounts of regular codeine, we're finding that there essentially hasn't been one of those patients that hasn't also developed a comorbid benzodiazepine. Well, if it's not dependency, it's certainly hazardous regular use. And so I'm just wondering how often, we know that the benzodiazepine usage in primary care is very high, and they're really, really fantastic drugs, really, really useful during acute distress, fantastic for, short-term treatment of panic disorder and anxiety while you're getting other pharmacological agents up to speed. But I just wanted to get it out there that if you've got somebody in your practice that's using regular benzodiazepines and you're providing prescriptions for regular benzodiazepine use, there's that issue of managing that, and I don't want to touch on that today. But what I do want to touch on is I think it's really worthwhile asking those patients about their over-the-counter usage of codeine. Because what we have found here is there is such a strong correlation between between codeine usage and benzodiazepine usage. And I think what's happening is they're using both medications as a way of enhancing their emotional state. And I think what's happening if their benzodiazepine usage, if they haven't got as much or if they fall short, often they're compensating by using the codeine. And I think we're also finding that if they, for whatever reasons, aren't getting sufficient access to codeine, they're supplementing or addressing some of the emotional and psychological withdrawal symptoms using benzodiazepines. So I think it's a far bigger problem than any of us have, well, certainly that I've come to recognise. And so I'm going to my 4th year here at Capri, and it's just something that's become really, really clear. And we don't know whether we're just seeing a biased view, and that is by the time you enter Capri, maybe hazardous use of benzodiazepines and codeine could be just related to the fact that we see a really biased small percentage of people. And I guess what I'm asking the wider audience of those that are potentially watching this podcast is if you've got somebody on benzodiazepines and they've been on benzodiazepines over an extended period of time, we probably will need a podcast just to address benzodiazepine use in primary care, and probably that would be a good topic to look at next month. But what I'm really asking for is whether or not you at the next time you see a patient of yours that you're prescribing regular benzodiazepines use for whatever reason, I'd really recommend asking about whether or not across-the-counter use of an opioid substance like codeine is happening at a much higher level than any of us really appreciate it. So this podcast for August, we'll keep it a little bit shorter. We reviewed our podcast from July, and that went on for sort of 16 minutes. And our goal is to keep the podcasts concise, to the point, and really useful, and keep it to a time frame between 8 to 10 minutes. And I think I've used up my allocated time. So looking forward to any feedback that you've got in relation to, the last couple of podcasts. Really interested in whether or not you're finding this useful. Our email address is there. Please give us some feedback, and look forward to getting any further questions. And what we might focus on in our next podcast is the growing challenge that is managing benzodiazepine dependency, both in primary care and through to sort of specialist services. Thanks very much.